Hello everyone, welcome to Nurse Bestie Explains. Today we'll see another video of 10 obstetrics and gynecology nursing important Viva questions. If exams are coming soon, those students will be benefited with this video. Let's continue the video. What are the 10 important OBG Viva questions? This will help you for better preparation and a quick preparation before the exam. First question is female pelvis. Okay, you need to know about the female pelvis. Very important in obstetrics. The female pelvis is a bony basin-shaped structure designed to support the upper body. Okay, it is a bony basin-shaped structure. Okay, and designed to support the upper body, protect the pelvic organs. What are the pelvic organs? You can see in the picture. Okay, uterus, ovaries, bladder. Okay, here is the urinary bladder and the rectum at the back of the uterus. Okay, these are the pelvic organs for female and facilitate childbirth. So this will facilitate the childbirth. Compared to the male pelvis, it is broader. Female pelvis is broader, shallower and lighter with a wider pubic angle. Pubic angle is very wide. That's why the childbirth is possible and a more spacious birth canal is present in the female pelvis. Key structures include innominate bones, sacrum and coccyx. You can see here innominate bone, sacrum and coccyx. If you see the female pelvis here, you can observe the bones. These are the hip bones. Okay, two hip bones, and the outer border is called as the iliac crest. You can see the picture. This is iliac crest. This is ilium. Okay, ilium. This side and right side and the left side. Ilium, iliac crest, anterior superior iliac spine. This edge is called as anterior superior iliac spine. And here inside, if you observe in the rim, two bony prominences, they are ischial spine. Okay, that those two prominences are ischial spine. After this is the space for acetabulum. Then this round thing is called as pelvic brim. And both pelvis brim come and join here. That is symphysis pubis. This region is called as symphysis pubis. And this is pubic bone. Okay, here it is called as pubic bone. Okay, ilium, iliac crest, anterior superior iliac spine. Inside these bony prominences are ischial spine and pelvic bone, pubic bone, pelvic brim, and pubic symphysis or symphysis pubis. And a bone which joins the two hip bones. Okay, pelvic bones is called as sacrum. Okay, sacrum, and it has a coccyx at the edge, and this is a promontory. This is called as a flat prominence. You can observe sacral promontory. So these are the parts of the female pelvis. Another question is types of female pelvis. In obstetrics, these four types of female pelvises are very important. Nurses should know this. First type is gynecoid pelvis, typical female pelvis. It is called as typical female pelvis, gynecoid pelvis. It rounded inlet. The inlet is round in shape, you can see, and wide transverse diameter. Okay, wide. This transverse diameter is very wide, most favorable for the normal vaginal delivery because of its unique gynecoid shape. It is most favorable for normal delivery. Second type is android pelvis. Okay, so android pelvis you can observe here heart shaped. Okay, not very broad like gynecoid pelvis. It is heart shaped. Okay, like this, and narrow anterior segment. Okay, anterior segment is narrow. Here you can see common cause of obstructed labor. This is the common cause, that is android pelvis is the common cause for obstructed labor. Third type of pelvis is anthropoid pelvis. Okay, so here oval inlet. You can see oval shaped inlet, anterior posterior long. Occipito-posterior positions are common with this inlet. Anthropoid pelvis, the fetal head position will be occipito-posterior positions are commonly seen. Vaginal delivery possible but prolonged labor. Vaginal delivery is possible but it takes lot of time for the effacement, the head to pass through this pelvic brim. It takes very long time. Fourth type of pelvis is platypelloid pelvis. Flat, wide, transverse oval. Okay, here you can see it's flat, wide, transverse edges. Short anterior-posterior diameter, short diameter, and engagement difficulty. It will be difficult for the head or the presenting part to engage into the pelvis brim. Okay, these are the four types of female pelvis. They are gynecoid pelvis, android pelvis, anthropoid pelvis, and platypelloid pelvis. Please remember the names: gynecoid, android, anthropoid, and platypelloid pelvis. Okay, next. Third question is fetus. What is fetus? Can you define fetus? You may get the question. A fetus is an unborn. Okay, the baby is still not born. Okay, that's why we call it as fetus. It is an unborn offspring of a mammal. Okay, baby of a mammal. That is nothing but the mother. Specifically, a human developing in the uterus. A human baby developing in the uterus from approximately 8 to 9 weeks. From 8 to 9 weeks after fertilization until the birth, that period only we call the fetus present in the womb, mother's uterus, we call as a fetus. Before that, we don't call as a fetus. 8 to 9 weeks after fertilization until birth. Okay, you can see here fetal developmental stages. Next question is fetal stages development. It starts with fertilization. Okay, after ovulation, after sexual intercourse, fertilization takes place. Once the egg is fertilized, then the fertilization process starts with the two cell stage, 4 cell stage, 8 cell stage, and 16 cell stage. After this week onwards, fetus starts developing. Slowly the fetal parts will develop, and you can clearly see the development. Okay, 5 weeks, 10 weeks, 20 weeks, and 40 weeks. Completion of the gestational period. Okay, up to this until 8 to 9 weeks, we call that part as a embryo. From here 8 weeks onwards till the birth, we call the baby as a fetus. Okay, so that is about fetus and fetal developmental stages. First trimester, second quarter, and the third quarter, fetus looks like that. Next, fetal skull. Okay, and next question is fetal skull. Okay, as you know, the pelvis is most important. At the same time, fetal skull is also very important Viva question, because you will find the pelvis and fetal skull on the table of the examiner. So knowing the fetal skull parts are very important. Okay. If you see this part, front part is called as face, brow, vertex, and occiput. These four things very important. Face, first start explaining about the fetal skull with face, brow, vertex, and occiput. This back side of this part is called as occiput. Okay. Then the more prominent things which you observe are fontanelle, anterior fontanelle and posterior fontanelle, very important. Then bones, frontal bones. You will observe two frontal bones, two parietal bones, two temporal bones, and two occipital bones. Okay, because this is showing only one side, so all will be two: frontal, parietal, temporal, and occipital bones. Okay, then you observe these lines. Okay, what are these sutures? These are the sutures. They are this suture. It starts from anterior fontanelle to temporal bone, where it ends. This is called as coronal suture. And another suture here near posterior fontanelle, you observe lambdoid suture. Okay, essential landmarks of the fetal skull. Already you have seen, you can see clearly. Two frontal bones, okay, two parietal bones, and occiput, okay, occiput, and anterior fontanelle, posterior fontanelle. These sutures which you observe, these are the this is sagittal suture, coronal suture, and the lambdoid suture. This is face, brim, vertex, and occiput, last part. Okay, parietal bones, two parietal bones. Okay, clear? Is it clear? Anterior fontanelle, which is diamond in shape, it is the junction where sagittal and coronal suture joins. That junction very soft to touch. After the baby is born up to few months, this anterior fontanelle will not close, where you will find a soft place where pulsations can be felt. And posterior fontanelle, it is a lambda, triangular in shape. Okay, here diamond, posterior fontanelle is triangular in shape. It is a junction of sagittal and lambdoid sutures. Sagittal and lambdoid sutures junction is called as posterior fontanelle. Okay, so these are the landmarks of fetal skull. Next, fetal head positions. Another question also you will get if you start explaining the mechanism of labor or anything. If you hold the pelvis and the fetal head in your hand, the examiner suddenly may ask to explain the fetal head positions, occiput orientation in labor. Okay, different fetal head positions. This side is called as anterior, left, right, and the posterior, back side. Okay, symphysis pubis towards this we call that as anterior. Okay, so coming to the common fetal head positions, OA, direct occiput anterior. Okay, direct occiput anterior. Okay, occiput touching the anterior. Then left occiput anterior. Left occiput anterior, most common and ideal presentation, left side. Left occiput anterior. Okay, anterior means like this, when chin flexed, very easy delivery, common position for comfortable vaginal delivery. Left occiput anterior. Then right occiput anterior. Again, the opposite direction. Right occiput anterior. Next, left occiput transverse. Left side occiput transverse direction. Right occiput transverse. Right side occiput transverse direction. LOP. Usually, if you observe the case sheets, these short forms only will be written at the findings of the abdominal or pelvic palpations. Okay, LOP is left occipital posterior, ROP right occiput posterior. Posterior means like this, head deflexed, difficult for the vaginal delivery. And OP is a direct occiput posterior. OA, OP. LOA, ROA, LOT, ROT, LOP, ROP. Okay. Direct occiput anterior, direct occiput posterior. Okay. Easy to understand. All the positions you have to remember. 1, 2, 3, 4, 5, 6, 7, 8. Total 8 fetal head positions we have seen. OA, occiput anterior, occiput posterior, left occiput anterior, right occiput anterior, left occiput transverse, right occiput transverse, left occiput posterior, and right occiput posterior. These are the fetal head positions. I hope you remember them nicely. Then key fetal head positions, which we have seen. OA is occiput anterior. Baby faces the mother's spine, back of head or occiput, which is ideal. And OP is the occiput posterior. Baby is head down. Head down but faces the mother's belly. Sunny side up can result in longer labor. OP result in longer labor. OT, occiput transverse. Okay, head is sideways facing the mother's hip. Okay, sideways. Breech. What do you mean by breech presentation? Instead of head, if feet or buttocks, which comes first in the vaginal delivery, the presenting part is feet or buttocks. We call that presentation as breech presentation. Next, common positions and characters. As you have seen in the previous question, LOA is the common presentation. Left occiput anterior or right occiput anterior, very comfortable for normal vaginal delivery. Baby's head is slightly off center to the left or right, facing the spine. These are the most common and favorable positions. This position we call it as vertex presentation because the top of the head is the first part to enter the birth canal. You can observe top of the head, vertex part of the head. Okay, skull you have seen in fetal skull, vertex part which comes, which is the presenting part and which is very normal. That is called as it is vertex presentation. If you check the station, refers to how low the head is in the pelvis, how low the head is in the pelvis, ranging from 5 -5 to +5. It is a score which is observed during the stages of labor. By seeing the score, we will observe that the head is coming down, visible, crowning. Okay, we call it as crowning. Based upon that, how much time it takes for delivery of the baby, you can estimate. Okay, position, presentation, and station. So these are the different birthing positions. Okay. The next question is very important. How do you calculate the expected date of the delivery? EDD, expected date of delivery. The common formula used is Nagel's formula. According to this formula, EDD is calculated as first day of the last menstrual period. If you ask the mother, when the mother comes for pregnancy checkups and all, first question which we ask is what is your last menstrual period, LMP. Okay, find out the first day of the previous month or 2 months back, whenever she had a menstrual period, the first day. Okay, that date plus add 7 days to it. To that again add 9 months. This is Nagel's formula for calculation of estimated date of delivery. For example, step 1, first day of last menstrual period is 1st January. Step 2 is add 7 days to it. Add 7 days, then it is 8th January. Step 3 is 8th January plus 9 months is equal to 8th October is the that mother's expected date of delivery. Note that this calculation assumes a regular 28-day cycle. If that woman is having regular 28-day cycle, this formula you will get the right answer. Okay, this is the for Nagel's formula for expected date of delivery. Very important. Ask for first day of last menstrual period LMP, add 7 days and 9 months to that. Very easy and simple formula for EDD. Next question is GT-PAL score simplified. Obstetric history at a glance. If you observe any pregnant mother's case sheet, you will find this GT-PAL score. Okay, what is GT-PAL? As an obstetric nurse, you need to know these abbreviations. So very important while reading the case sheet. You will understand. So what is G means is gravida, total number of pregnancies, how many times the mother is pregnant, whether the children are born or not born, died, abortion, whatever, doesn't matter. How many times the mother got pregnant, that number. Example, you can see G3, 3 times she got pregnant. Term births, full term births without delivering in 8 months, 7 months. Full term deliveries, how many deliveries more than or equal to 37 weeks of gestation? How many terms? Okay, T1. She had only one full term birth here in this example. What is PP for 3 term births? Okay, deliveries between 20 to 36 weeks. Abortion, A for abortions. How many abortions she had? Pregnancy loss less than 20 weeks, including induced. You have undergone abortion or spontaneously abortion happened, whatever the number of abortions you have to write. Here it is A0. L, L means living children. How many living children the mother has currently? How many living children, offspring she has? That is mentioned here, L2. The mother was pregnant for 3 times and term birth is 1, premature preterm birth is 1, 0 abortions, now living children 2, and she is carrying another baby like that. Okay, GTPAL provides detailed obstetric history. By just seeing the score in the patient case sheet or OP card, you will understand the detailed obstetric history of that pregnant mother. Okay, so this is the GTPAL score explained. Next question is fundal examination. Very important in antenatal assessment of the mother. Okay, antenatal care, fundal examination. Before going to the fundal examination, we will see about antenatal care. How many visits are very important in pregnancy? According to WHO, every pregnant woman should complete minimum 8 antenatal checkups in 9 months for a safe and healthy pregnancy. 8 antenatal checkups in 9 months. Okay, so the schedule goes like this. This schedule is given by WHO in 2016. First visit at 12 weeks, okay, 12 weeks, at 20 weeks, second visit, 26 weeks, third visit, 30 weeks, fourth visit, 34 weeks, fifth visit, 36 weeks. As the weeks are progressing, coming near to the delivery, we will have frequent, okay, every 4 weeks, here 34, okay, immediately after 1 month, there is fifth visit. After 2 weeks itself, there is sixth visit. Again, after 2 weeks, seventh visit. Again, after 2 weeks, eighth visit. Very important. At the end of the term, frequent visits we have to make. Benefits of 8 antenatal visits are reduce health risks. Any health problems mother developing during pregnancy, you can identify those high risk cases easily, monitor fetal growth, improve maternal well-being. and improve guidance and counseling. You can talk if any diseases or any fetal malformations if you identify. You can give guidance and counseling to the couple or the mother and detect complications. If you do scans in the fourth visit at 26 weeks, 20 weeks, the fetal development you will identify, so you can detect complications and then prepare the mother for delivery. Birth preparedness, nutrition and supplementation advice also you can give. These are the basic antenatal care according to WHO. Antenatal visits. Okay, total 8 antenatal visits in 9 months of pregnancy duration. Next, coming to the fundal examination, very important procedure. For this procedure, pre-procedure actions include empty the bladder. Ask the mother to empty the bladder before you start, or when you go to the bedside, mother ask the mother, did you empty the bladder? If not, go to washroom, come back. Like that, you should ask the mother. Then you have to start your examination. The mother should empty her bladder within 30 minutes prior to the measurement to prevent an elevated uterus which can cause inaccurate readings. Okay, bladder should be emptied. Then positioning. Position the pregnant person in a supine, flat on back or semi-recumbent position with 45-degree angle with legs straight or slightly flexed. You can allow. A small pillow under the head is recommended for comfort. That is the position. Very important positioning. Safety check. If the gravid uterus is very large, consider placing a small pillow or roll towel under the right buttock to prevent compression of inferior vena cava. Remember this point. If the uterus is large, you can place a pillow under the right buttock to prevent compression in the inferior vena cava. Then preparation. Explain the procedure to the patient and obtain consent. Expose the abdomen from the grippy sternum, the edge, last point of the sternum. From there to the symphysis pubis, you have to expose, cover the rest of the body parts with bedsheet or mother's clothes. Okay, then equipment, ensure a non-elastic centimeter tape measure is available. You can set the tray which has generally for antenatal assessment, not only for fundal examination. Overall, if you start the antenatal assessment, basic tools like BP apparatus, stethoscope, thermometer, hand sanitizer, measuring tape, very important, kidney tray, and some cotton swabs and Pinard's stethoscope, okay, fetoscope, fetal Doppler if you are certified to use it. Then urine testing, HB testing kit and urine testing strip you can take. Examination table necessary with a pillow, gloves, antenatal register to record the findings, and mother's record pen, waste disposal bag, kidney tray with paper bag you can take. Okay, so this is the basic equipment. Then inch measuring tape is very important. Clinician preparation, wash hands. The person who is conducting examination should wash hands and ensure hands are warm to avoid causing uterine contact. Before starting, just if you are not wearing gloves, so rub your hands, make them warm, then touch the mother's abdomen. Okay, like this. You have to stand at the right side and face towards the mother. Okay, like this you have to stand, palpate the abdomen. And before starting this inspection, palpation and auscultation, follow these 3 steps. First inspect, don't touch it, just inspect the shape, any stretch marks, all those things, changes in the skin, abdominal skin changes, stretch marks, everything, previous operation scars, all that you can inspect, then palpation and then auscultation. Okay, like this you can start your palpation, okay, measuring the fundal height with the measuring tape, auscultation with stethoscope. After doing these 2 steps, you will identify which side the baby is back. There you can mark and check with the stethoscope and count the fetal heart rate. Okay. Next, fundal height monitoring. How you will check fundal height monitoring? You can observe in the picture here with the inch tape from the zippy sternum to the symphysis pubis. If you measure with the inch tape, you will get it in centimeters. Okay, 12 weeks, 16, 22 weeks above the umbilicus. Okay, 28 weeks, 32, 36, 40 and 38 weeks. Okay, 40 weeks, why it is coming down? Because slowly as the nearing to the labor delivery, the head will descend so that the fundal height will be lesser. 12 weeks symphysis pubis. 20 weeks till umbilicus. Okay, till umbilicus it will grow. 36 weeks up to xiphoid process, sternum edge. Okay, 37 to 40 weeks regression of fundal height between 32 to 36 centimeter. Postmortem less than 24 hours till umbilicus you can feel the abdomen. Here you can see. Okay, from zippy sternum to the symphysis pubis measure with an inch tape. That much centimeters is the fundal height of the mother. Okay, for determination of gestational age, fundal height will be important. Okay, from where to where we will measure the fundal height. If examiner asks zippy sternum to the symphysis pubis, and at different weeks, whatever the position, the estimation of gestation age. Okay. So thank you. These are the 10 important questions. I hope they are very clear and very brief, very important for the exam point of view. We will continue in the next video with 10 more important questions for the practical Viva of obstetrics nursing and midwifery questions. Okay. Please like, comment, share and subscribe. Thanks for watching.